Hey everyone, this is Jeff Sparks from Brigham and Women's Hospital in Boston, Massachusetts, and we are here at Chicago for day 2 of the 2025 ACR Convergence annual meeting. Today I'm going to be talking about new paradigms for the treatment of rheumatoid arthritis. Obviously we have a lot of great treatments for RA, but a lot of our patients are still suffering. And there haven't been a lot of advances over the past decade. Certainly a lot of other diseases have benefited from this, but I think RA has languished a bit, but luckily there's 3 trials I wanted to talk about here that are really paradigm shifting, at least the potential to be paradigm shifting for rheumatoid arthritis. The first I'll talk about is Reset RA, which is an implantable left vagus nerve stimulation. So obviously this is very different from any other treatment that's ever been approved for rheumatoid arthritis before. This involves a surgical procedure, overall relatively minor, but certainly different to refer your patient to a neurosurgeon to have this implantable device. And this periodically stimulates the left vagus nerve, which has been shown to decrease inflammatory markers. So there were 2 abstracts that were interesting from this Reset RA study. The first abstract, 1675, reported the primary results. And the primary outcome was an ACR 20 at month 3. And this was randomized to basically turn the device on or to have a sham where basically the procedure was implanted but not turned on. So in 1675, showed that the ACR 20 was hit in around 40% of patients compared to less than 20% of those with the sham intervention, and this was statistically significant. And this showed that this neuroimmunomodulation could be helpful and efficacious to treat RA, and many of these had failed several biologics. I think a particularly interesting part of this is that there continued to be improvement in month 3 where all patients crossed over into the active arm, and it seemed like this was overall pretty well tolerated. There were some patients who had some hoarseness and dysphonia, but overall not thought to be too severe. A corollary subgroup analysis of this was 2614, and this was looking at basically radiologic progression, looking at MRI scores. And this is not something I necessarily expected, that a neuroimmunomodulator would actually decrease the progression of structural damage in rheumatoid arthritis. And overall, there was a trend towards statistical significance in the intention to treat analysis. However, in a subgroup analysis where they restricted it to people who are at high risk of developing or worsening Rosens, particularly if radiographic features at baseline, it was statistically significant. So this is a real proof of concept that this could be a very different therapy to offer our patients. The next study I'll briefly highlight is the Renoir study, LB19, a late breaker. This is a phase 2B study looking at rosnilimab. This is a study that depletes pathogenic T cells. In one of my previous videos, we talked about T peripheral helper cells, T follicular helper cells, which seem to be present in higher numbers, particularly in people at risk for rheumatoid arthritis and those that are seropositive. So this study randomized people to rosnilimab versus placebo, and this also hit its primary outcome of hitting an ACR 20, and also had differences in ACR 70 as well as many other secondary outcomes, and was also very safe and well tolerated. And I think that should lead this towards maybe perhaps a phase 3 study that would really need to be established efficacy and safety. The last study is LB23 that I'll highlight, and this is a CAR T study. However, it's a different kind of CAR T study because the T cell that they use is a Treg, and because this cell is relatively a peacemaker, if you will, this one doesn't actually need chemotherapy. It isn't expected to have much side effects, and it's also targeted against citrullinated antigens that are specifically implicated in RA pathogenesis, as opposed to CD19 that many of the other CARs. So this is a different kind of CAR T trial. And this is very early study, just phase 1, and there did seem to be some transient benefit. I'll say that compared to the CD19, this was not as efficacious. However, this is a dose-finding study, and perhaps a higher dose might be needed for more lasting effects. But again, I think this illustrates how CAR T could be used in many different ways besides just a CD19 CAR T effector cell. So these are just 3 examples of some potential paradigm-shifting studies within rheumatoid arthritis. to highlight, we're talking about neuroimmunomodulation with an implantable device. We're talking about depleting pathogenic T cells, and we're also talking about actually using CAR Tregs as a anti-inflammatory in a CAR T environment. So again, thank you for your attention, and hopefully you're learning a lot at ACR 25, and I'll look forward for more reports. Thank you.